Okay, let's try this again. Welcome to Nursing 203, Chapter 81, Part 2. Had this mostly recorded and then computers. So, I believe we left off about here. Slide. Come on. Around current slide. There we go. So, nursing considerations before cardiovascular procedures, right? Pre-op teaching them what to expect both before the surgery and after the surgery. If they are going to have mobility restrictions, if there are going to be other restrictions on them in the recovery phase. We also start the discharge planning. We start the discharge planning when they walk through the door. And plans for cardiac rehabilitation. We will be looking at the client's nutritional status and their capacity for healing. Are they malnourished, either over or undernourished? Do they have conditions that may impact their healing by slowing the healing process or creating a higher risk of infection? Supplemental oxygen needs. Your patient pre-surgery may require supplemental oxygen because, as you recall, the red blood cell really has one job, and that's to supply oxygen to the tissues. If the oxygen is restricted, say due to a constricted blood vessel or a blockage that we're going in to surgically fix or bypass, the patient, we want to pack those red blood cells that might be getting through with the maximum amount of oxygen they can handle to get the maximum amount of oxygen to the tissues. After surgery, they may not require the supplemental oxygen, or they may be able to come off of it at a time after surgery when the healing has begun to really progress. Vitamin and mineral therapy. Think vitamins, vital minerals. They are required, they are necessary for proper cellular function for healing and repair. And then the routine tests and procedures. So blood tests, functional tests, there are a number of things that would be looking for that will be more specific to the surgery that the patient's undergoing. Very important, oddly enough, first thing up, airway and ventilation, maintaining airway and ventilation for the patient. As you recall, ABCs, if you don't have A, B, and C don't matter. Providing adequate tissue oxygenation through working with cardiac output and supplemental oxygen, or our other possibly non-pharmacologic therapies such as promoting deep breathing and coughing. Okay, monitoring and maintaining cardiac function. Close eye on the cardiac output, or at least the signs of adequate cardiac output. Be monitoring blood pressure, heart rate, all these various pieces. Maintaining fluid and electrolyte balance. We know that electrolytes are necessary for muscle contraction. We're talking about cardiovascular. We're talking about one really big important muscle. Too much or too little fluid. Too little fluid, the patient becomes hypovolemic and their blood pressure drops, leading to perfusion issues. Too much, and you can stress the areas that are being that have just been repaired, or cause edema in the systemic circulation in the lungs, This edema can impair healing and really be life-threatening. Controlling chest drainage with suction, or even not necessarily even suction, but with a chest drainage system. Consider that when we've been cutting into the thorax, there will be bleeding, there will be inflammation. Along with inflammation comes leaky capillaries. And with leaky capillaries comes fluid getting out of the vasculature into the tissues. In the case of a cardiovascular surgery, there's a couple of places that that fluid can get to that can cause some really big issues with respiratory and cardiovascular status. For one, as you may recall from Nursing 103, the chest is a semi-closed system. There is really only one way that air should be entering and leaving, and that is through the airways. The diaphragm flattens, tries to create a vacuum. Atmospheric pressure pushes the air through the airway into the lungs, causing them to expand into the space that's created. If that space is filled with air or fluid, then the lungs do not have a space to expand into, and then you lose vital real estate for gas exchange, bringing in more oxygen, getting rid of the CO2. So a chest drainage system is placed to drain that fluid off so that the lungs have the maximum amount of space that they can expand into. Another place that fluid can collect that's not controlled with the chest drainage system, but is in this sac around the heart, the pericardium. We'll talk about that here a little bit in a little bit more depth. God willing, and the computer doesn't crash again. But in this basics, your heart, as it beats, has to expand and contract. There's a sac that surrounds that, 2 layers with a little bit of fluid inside to block any friction that would be happening there, and your heart can beat. If fluid collects in that, here's a virtual foot stomp. You have a condition called cardiac tamponade, where fluid collects, blood collects in between the layers of the pericardium and impairs the heart's ability to expand. So I'm going to introduce you to another one of those little equations that I like to give you. Let me stop this for a second. And bring up the whiteboard. Okay, now I do not promise great artwork. So let's start with our heart. Okay, we have our heart. And I'm just going to draw in some lines here to denote the 4 chambers of the heart. Up here on top, we have the atriums, or atria. Down here on the bottom, we have the ventricles, A, V. Okay. Let's do valves in green. And then we've got a little valve here, and a little valve here, and another valve here, and another valve here. Okay, so yes, and the last piece. So which is the right and which is the left? Remember, we're looking at this from the front, so it is anatomical right and left. So in this case, here's the right, and here's the left. All right, with me so far? All right. So when I say your heart's a pump, it's actually 2 pumps, right? Let me draw a little divider in here. Let's go dark green for the divider. And a thicker line. So Here's our division. Right down. That's called the septum. Okay. It separates right from left. So, and then around here, let's make it sky blue. Why not? I'm just going to draw one layer of this. We will all have to agree that the other layer is directly on the epicardium. Okay, so here's your pericardium. In here is the pericardial space. All right, so your heart is beating. Right, a little bit of fluid in between these layers here, and it moves without friction. Should this begin to fill with fluid, right, we lose space for, and let me draw in some fluid here. All right. Now this fills the fluid, and you can see now that there is less space for the heart to expand into. All right. Now to the equation. CO equals SV times HR. That's an R. There. That better? Okay, stroke volume times heart rate. CO, cardiac output. That is how much blood is being ejected from the ventricle into the system with each stroke. All right, stroke volume. So let's just throw some round numbers here. Let's say normally we would be stroke volume of, let's say, 50. Okay. With cardiac tamponade, let's say it's 30. All right. We'll just say an equal heart rate of 80. So 50 times 80. Five times 8 is 40. So let's say this is milliliters and this is beats per minute. So if it was 50 mils with each stroke being pumped out, 4,000 milliliters per minute. All right. Now we fill this space up 30 times 80. So 400 mils per minute. Okay. That doesn't seem like a bunch, right? Well, that's a fairly big chunk. I mean, figure that you're only sitting at 3/5 of what it would normally be. Okay. So this can impact the cardiac output. Your body relies on the cardiac output to meet the metabolic demands of the tissues in the body. Okay. So cardiac tamponade fills that up, decrease the cardiac output. Now here's the thinking question for you. So my body says, my cardiac output has dropped. What happens? What happens to my heart rate when my body senses that my cardiac output has dropped? If you just yelled at your screen that the heart rate goes up, then pat yourself on the back. You're right. So with cardiac tamponade, there's a couple of things that you will see happening. One, the jugular veins will become distended, and we'll get to that here in just a second. Two, the heart rate will go up because three, the blood pressure has dropped, because blood pressure is a kind of a window as to, you know, how my heart is able to meet the demands, right? And number four, when I listen to the heart sounds, remember that when you hear the lub and dub, it's not this chamber or this chamber contracting. What you hear, the sound, is the closing of these valves. So the atria up here contracts and it pushes blood down through this valve, and then it begins to relax and that valve closes, right? And then the blood comes out here as the ventricle contracts and it pushes the blood out through there, and then as the contraction is over, then that valve closes. That's the lub and dub that you're hearing. Now, consider that this accumulation of fluid that is now surrounding the heart, let's make that this accumulation of fluid is further impacting your ability to hear it, because now that sound not only has to go through all the tissues that it's going through to get to you, to the bell of your stethoscope, but now you have an extra layer of fluid in between there. So it's muffled heart sounds for cardiac tamponade. Okay. Now I'm going to take these and whoop. Oh. Okay. And then I'm going to draw that back in. Not quite sure what happened there, but all right. All right. This is one funky looking heart, guys. Okay. So, next piece we're going to do. So the blood is pumped out here. Right, and it goes out. And here's a capillary bed, one of billions. Oh, come on now. All right, and then returns here. And I'm going to draw in a couple of lungs. They'll be okay. That's as good as the lungs get. Sorry, guys. All right. Okay. So, one last little draw here. All right. So we have up here, we have the superior vena cava, big vessel, draining from everything above the heart. That's where all the venous return is coming in. We have the inferior vena cava, generally without a dog leg in it, where all the venous return from the body is coming, right? These come into the right atrium, through the right AV valve into the right ventricle, which is then pumped out through the, whoops, I drew those valves in the wrong place, but you get the picture, which is then pumped out through the pulmonary semilunar valve, or the pulmonary valve, to the lungs. This is all deoxygenated blood. This is venous return, venous blood. Oxygen and CO2 exchanged in the lungs. Oxygenated blood is returned to the left atrium, which is then pushed through the left AV valve into the left ventricle, then pushed through the aortic valve out to the body, through the capillaries where oxygen is exchanged for CO2, and the cycle repeats itself, kind of like the nursing process. Okay? So, as I said, the heart is a pair of pumps. On the right-hand side here, if this is unable to expand due to that fluid there, this blood backs up. And you see that in the jugular veins as they become more prominent because they're not being drained. Does that make sense? Okay. Stop that share. And let's go back to, let's see if this one does it. Okay. So identifying the signs and symptoms of complications, which will be different. Almost forgot body temperature. Two ways that you may see. One, the patient is hypothermic, especially just post-surgery. Body temperature is lowered to slow metabolism to reduce tissue damage. But what might we suspect if my patient post-surgical has an elevated body temperature? If you just screamed infection at the screen, well, you're playing along and you are right. Signs and symptoms of complications. So we just talked a bit about cardiac tamponade. By the way, go back and review that. You may see it again on a test or two. The signs and symptoms of complications. Well, I mean, a surgery is a surgery is a surgery. Right? So you have the basics, the anesthesia complications, you got pain, you got inflammation, you got hemorrhage, you got infection. Okay. The location, now you may have airway issues. Again, we're talking about the controlled chest drainage. You might have complications related to the hemorrhage with cardiac tamponade. Right? So knowing what's going on in those systems and knowing what the signs and symptoms of the complications would be for each of these procedures. Relieving pain, because these are pretty painful processes that we're putting the patients through. Splitting the sternum, jacking it open, fixing the plumbing, drilling a bunch of holes in the sternum so it can be wired back together, stitched up, chest tube placed, sent to PACU, sent to ICU, sent to step down, where the nurses are saying, okay, Bob, I want you to take 5 good deep breaths for me and then cough. And then Bob questions your parentage because that hurts. So relieving pain is a very important piece of some of these procedures. Now, here's one of the tricks is that what do we go to very often to relieve pain? We go to narcotics. What can narcotics do to blood pressure? If you said drop them, you'd be right. But also respiratory rate. CNS depression impact our respiratory rate. And this does not help us trying to get Bob's lungs fully inflated to prevent atelectasis and pneumonia. So we have to employ non-pharmacologic measures along with just giving them shots and pills. Okay. One of that is, one piece is splinting. We're teaching them how to use a pillow to splint when they're coughing and deep breathing to minimize the pain. And that, hold on. There we go. Nursing process. Huh. Well, not to beat a dead horse, but everything and pie, right? In this case, one piece for cardiac patients, teaching about prevention. Why, Sean? Why would, I mean, it's a little late to teach them about prevention, isn't it? But prevention of the next admission, right? Prevention of the next admission. Try to keep from seeing Bob back in the bed and just seeing Bob out on the street somewhere. Hopefully not chowing down on a bag, shopping bag full of McDonald's cheeseburgers. And an evaluation, did it work? If it didn't work, then we go back through assessment, planning, implementation, and evaluation again. That never-ending cycle that we have called the nursing process, much like the cardiac cycle, it goes on and on and on and until death. So, abnormal conditions that can cause cardiovascular disease. Know these two pieces, right? Know the differences. Arteriosclerosis and atherosclerosis. Seriously, know them. It may be on a test. Okay. So arteriosclerosis, hardening of the arteries, comes with age, wear, and tear generally. Uncontrolled hypertension, advanced age, the arteries lose compliance. They lose their ability to stretch and contract. Right? Atherosclerosis leads to a loss of compliance in the artery as well, but it's due to the deposition of these fatty plaques. So you have your arterial wall, and then you get this collection of cholesterol, this fatty plaque that starts to lay in there, and it shrinks the size of the lumen of the artery, and it also impairs its ability to expand and contract. Okay. What this can lead to, especially with our fairly typical developed world diet, is arteries that look like a very old sewer pipe with lots of collections, which doesn't expand well and likes to catch clots, which can further impair blood flow and bring on things like stroke and MI, right? MI, myocardial infarction. Hypertension. One of the most common cardiovascular, I believe it is actually the most common cardiovascular diagnosis, right? Hypertension, high blood pressure, right? Leading cause of myocardial infarction and CVA, cerebrovascular accident or stroke. Causes cardiac damage, stress, wear, and tear on the cardiac muscle. Cause kidney damage. As we've talked before about kidneys, they are so very important, but they take damage so very easily. Very complex and delicate structures in the kidney that do not respond well to a lifetime of uncontrolled hypertension. And then heart failure. As just discussed, the heart is a pump, right? It's a pair of pumps. Heart failure, very basically, is something that has impacted the heart's ability to pump. It's just a pump failure. Congestive heart failure, just as we were talking earlier about tamponade and not being able to, the jugular veins being distended because the blood's not being drained from those as quickly. With congestive heart failure, or as more commonly now, chronic heart failure, the fluid is either not being drained from the tissues, or it is not being drained from, say the tissues of the body, or not from the lungs, causing fluid to back up and water to come out of the vasculature into the tissues, causing edema. We'll revisit that here in just a second. Hypotension. Hypotension can be from a heart rate problem. We'll be able to revisit that too here in a moment. a heart muscle or pump problem, or a volume problem, hypotension, low blood pressure. If your circulating blood volume is too low, we'll have hypotension. If the heart muscle or the structure of the heart are damaged and are not functioning properly anymore, you may have hypotension. Or if your heart rate is too low, so that your cardiac output decreases, then you will have hypotension. So let's go back to the drawing. There we go. Okay, we're back here to the drawing. Yay, look at this. Okay, so here's our pumps, right? Here's the side that we draw from. So this is upstream, okay? Here too is upstream. From the lungs are upstream of the left side of the heart. The systemic circulation is upstream of the right side of the heart. So when we think about heart failure, the cause is downstream. Okay, the effects are felt upstream. Let me. All right, for hypotension, just before I go clearing this off and going on to the next one here. So for hypotension, remember cardiac output, stroke volume times heart rate. I verbally got ahead of myself there. My stroke volume, unless something acts on it from outside, my stroke volume is not going to change. My heart rate will change. So if my stroke volume remains at 80, my stroke volume remains at 50, but my heart rate drops to 40, taking this, this first piece right here. So this is my stroke volume saying at 50, my heart rate at 80, I was putting out 4,000 milliliters per minute. Okay. Now if my heart rate drops to 40, now I'm down to 2,000 milliliters per minute. What do you think my blood pressure is going to do? What's my organ perfusion going to do? They're not going to be perfused, and I'm going to start ending up with end organ damage. Hypertension, kind of a silent killer there, but hypotension can do it much more quickly. Right? So we're talking about here's upstream with the tamponade, right? Up here, you'd see the jugular vein distension with heart failure. So let's say this right side, it's right because you have right-sided and left-sided and total heart failure. Kind of self-descriptive, right? Right-sided heart failure, it's not drawing from the body, fluid backs up down here, and that's where you see the edema. Left-sided heart failure, it's not drawing from the lungs, fluid backs up in here, and you have that's where you have the edema. Now you may not see that edema, but you will definitely hear it, and you will see it in your patient as they are fighting to breathe. Okay, let's do an eraser and just clear this whole bad boy here. All right. We're going to draw all right. And nope. Come on. I know they're funny looking plants. And Okay, so what am I doing here? I'm often asked that. Sometimes the answer is, I don't know. Okay, so let's go with some water. Probably ought to extend those stems a little bit. Okay, this is another one of those analogies that I like. All right, so here, not there. Draw. Here's Farmer Bob. Okay, Farmer Bob, he's been having himself a pretty good year, and because his crops are doing well, right? You can see here he's got his irrigation ditch, he's got his crops down here, he's got his high-tech dam and an irrigation pump that provides just enough, not too much, not too little, water for these plants downstream to meet their metabolic demands so that they can grow and function and do their little plant things. Okay. So Bob's been having a pretty good year. So Bob went out and he bought himself a pair of, wow, those are, okay, those are funky looking boots. A pair of brand new red Tony Llama boots because he's doing all right. And you see Bob is happy. See that's smile right there. All right, Bob is happy because his pump is working fine. It's drawing from upstream just perfectly and putting it out downstream, and all those plants downstream are able to have their metabolic demands met. Okay. But Bob should not necessarily maybe have spent the money on his Tony Llama boots. He should have spent it on maintaining his pump, because Bob's pump is getting old and wearing out. That would be smoke. Bob's pump is wearing out. What happens when it wears out? It doesn't pump as efficiently. So what happens here next, come on, is we have a little problem because now it's not pumping as well. And you can see those plants are not really getting their metabolic demands met. Okay. Well, that's a bummer. You know, that pump is going. But let's look at what happens upstream. Because the flow is still coming, but it's not being pumped as efficiently. So it starts to back up, right? As it starts to back up, you know, this pump isn't working as well. It's not moving as much to the other side of the dam. The water backs up and soaks Bob's Tony Llama boots. Which makes Bob sad. Right? So this analogy, using that pump is one side of the heart. If this is the pulmonary circulation, okay, then this is the systemic circulation. This is the right side of the heart. If the right side of the heart begins to fail, fluid backs up into the systemic circulation, and that's where you see those patients that have the very edematous lower legs and ankles, right? If this was the left side of the heart, this is the systemic circulation, this is the pulmonary circulation, right? Fluid backing up into the lungs, and then that causes edema in the lungs, causes the lungs to fill with fluid, and you get the crackles, the foamy, the hypoxia, the patient fighting for air. Make sense? Okay. All right. Now we get into rhythm, or rhythms and dysrhythmias. So cardiac dysrhythmias. Now you can have an arrhythmia that is not a dysrhythmia. Okay, arrhythmia means no rhythm. Dysrhythmia means a rhythm that is causing a problem. Okay, so sinus tachycardia, heart rate is too fast. Okay, sinus bradycardia, heart rate is too slow. Premature ventricular contractions. Let's see if I can do this on the small screen. So atria, ventricles. Atria, ventricles. Right? Atria squeezing blood down into the ventricles. They really have one job, is to squeeze the blood into the ventricles, cause a little bit of a stretch, and then the ventricles contract and squirt the blood out. Right? Premature ventricular contraction. So this contracts, electrical impulses come down, cause the ventricles to contract. Right? Electrical going. A premature ventricular contraction means that this is done, and then there's a second ventricular contraction. The atria is not triggering it, it's irritable heart muscle. What this can do is, well, one, the ventricle has not had a chance to fill with blood from the atrial contraction, so it's not really doing that much for a pump. Two, if that heart muscle depolarizes at the wrong time, as the original beat is repolarizing, getting set again, if that depolarization happens again, it can cause ventricular fibrillation, and no pumping at all is happening at that point. Right? AV heart block. Okay, back to the drawings. Whiteboard. All right. Bye, Bob. Okay. We're going to draw another heart. I'm going to try to draw it a little bit bigger this time so it's easier to see. So here we have a heart. Yeah, we're going to pretend that didn't happen. All right. Now we've got our 4 chambers. So, electrical. Up here we have this little group of cells called the SA node. And we have a little group of cells here called the AV node. All right. And then we'll go like this. Then we have this bundle of nerve fibers called a bundle of HIS, which then splits into the right and left bundle branches. And then off the end of those are these little things called Purkinje fibers, which there are a lot more of them. They are essentially little electric wires that take the electrical impulse to the entire surface of the ventricle. There are little fibers like this up here too that go across the atria. All right. So we got a little internodal pathway here. Let me see if I can, between the SA and the AV node. Okay. And it shoots out here. So when the SA node fires, we use yellow. When the SA node fires, it sends this depolarization across the surface of the atrium, causing the muscle to contract in unison, right, through all these little fibers. It also sends it down this internodal pathway between the SA and the AV node. The AV node takes that impulse and holds it just for a little bit before it fires out through the bundle of His, down the bundle branches, and then out through the Purkinje fibers, which then cause the ventricles to depolarize all at once. So boom, 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 right? When you are looking at it on an EKG, it looks something like, let's get something that's visible. It looks something like this. That's a P wave. That is the SA node firing and the atria depolarizing. This is electrical activity that we're reading here. And then we got this little pause called the PR interval. And then this next wave, QRS, right, which is the electrical activity of the ventricles firing, contracting. And then we got a little pause here, ST segment, and then we get a T wave, which is the ventricles resetting their electrical potential, and they're ready to fire again. Okay, this is what we'd call a sinus rhythm, because then it does another P, PR, Q, R, S, and a T, and it goes on and on and on until death. So what happens here is this firing, there's that time delay, and then the impulse continues on and causes this to fire. Sinus beat, meaning it starts from this, it's controlled by the sinoatrial node, right? These are connected, these are related. Well, okay, so it looks like you got a little wandering atrial pacemaker here, but anyway, these this beat is related to this beat. You know, this is related to this. If I looked at it on EKG, these would be equal as it went on, and these would be equal distance apart. Okay. Now, if I have a block at the AV node, let's say I have something that is just kind of slowing that impulse down, right? Then I'd have my P wave, but I'd have a PR interval that was a lot longer before I got my QRS, my T. The P, no longer, QRS. and a T. Okay, so that can extend that time. Sometimes, so this would be a first degree block, where this PR interval, even though it's long, it's consistent in between beats. The QRS complex, they march out, the P's march out. They're equal. It's just a long interval in between the P and the QRS. Second degree, we've got a couple of these where the PR interval starts out normal, and then it gets longer, and it gets longer, and it may get longer again, and then they'll set back to normal. Okay, so it gives you a regularly irregular heartbeat. So it'd be dum boom, dum boom. It's regularly irregular. With another type of the second degree heart block called Winky Bach, then it will get longer, and it will get longer, and it will get longer, and eventually there will be a P wave that is not followed by a QRS. There will be a little pause there, and then the next P wave hits, and it starts out normal, gets longer, gets longer, gets longer. Okay. The third piece, and those can be brought on, these blocks can be brought on by medication or damage. This third piece here is something has completely blocked that AV node, meaning there is none of this impulse is getting through from here to here, right? From the SA to the AV, none of that impulse is, the impulse is going from here to here, but it's not getting through the AV node. Cool thing about the SA node, it's kind of OCD. It fires, and it keeps its rhythm, right? Right? It keeps its rhythm. Ventricle has its own automatic depolarization as well. It's just very slow. We're talking around 20 beats a minute, which is not compatible with life for very long. So what's happening is, what you'll see, this is always a tricky one to draw, is I've got a P wave, 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 and then I will have a large, funny-looking QRS. I'll have a large, funny-looking QRS, which is, and the P waves will all march out. They will all be consistent. The QRSs will all march out. They will all be consistent. But the P's and the QRSs will not have any relation to each other. Where the atrium may be going at 78 beats a minute, and the ventricles are going at 20. They're just kind of doing their own thing, right? So electrical activity there. Let me stop this particular share. All right. Okay, so with an AV block, especially a third degree AV block, that is the one that the atria and the ventricles are just not talking to each other anymore. These are the patients that are prime candidates for a pacemaker. Right? Knock, knock, knock. And also review in your textbook nursing considerations and patient teaching about pacemakers and ICDs. ICDs, what we're going to talk about next, well, defibrillators. So fibrillation. Normally we have boom, boom, right? Coordinated beats. Fibrillation, we're doing this. You could have atrial fibrillation, where the atria are just kind of a bag of worms, but the ventricles are still doing what they should be doing, because some of that electrical impulse is getting through the AV node and triggering a depolarization. So it may not be a consistent beat. It might not be something that you can set your watch to, but people walk around in a fib all the time without issue. Sometimes they don't even know that they've got a condition until they're in the hospital for something else and it's discovered. Okay. Ventricular fibrillation, on the other hand, so we know that the atria has one job. It's really to fill the ventricles, give them a little bit of stretch so that they can contract harder. The ventricles have the big job. They do the lion's share of the work. They are doing all of the pumping to the pulmonary and the systemic circulation. If they're doing this, no pumping is happening, meaning that the tissues downstream from that pump are getting no cardiac output, and that is incompatible with life. So what's the cure for fibrillation? Well, if you're reading on the slide there, you'll see defibrillation. I wonder if that has something to do with it. Yes. Also something that we like to call Edison medicine, the application of electricity to, because remember, we're talking about electrical activity of the heart here causing these funky movements. We apply electricity to reset the process. And I'm sure you have all seen it on TV and ER, whatever. They're clear and they hit them. Well, of course, you've taken your CPR course, so you know how to use an automatic external defibrillator, or AED. Same thing. It's applying electricity to reset that cardiac cycle there, that electrical cycle. We also have an implantable cardioverter defibrillator, or ICD, which is the same size or a little larger than the pacemaker. And in some cases, what may be implanted is both a pacemaker and a defibrillator. But this does the same thing. It just applies it directly through leads, directly to the heart muscle, instead of sending that jolt of electricity through the tissues of the body, through the heart to reset it. Review patient teaching for that. Yeah, this would be the point where I would do the foot stomp, because you may see this again. All right. So CHF, talked about that already here. The heart's ability to pump. So hemodynamic monitoring, right? One way in which we do that bedside, blood pressure. But here is again where we do the I's and O's and daily weights. In class, I would throw a bunch of 1 liter bags at you and tell you, okay, now put those on your chest and walk around with them for a while. A little hard to do that in this environment, so go get yourself a liter bottle of your favorite non-alcoholic beverage, or go get 2 of them, and then let's see, for right-sided heart failure, strap them to your ankles and walk around with them. For left-sided heart failure, think about that weight sitting on your chest all the time and realize that 2 of these, all right, 2 of these, 2 liters is 4.4 pounds. That's 4.4 pounds. So 5 pounds of weight gain in a couple of days means that your patient has just north of 2 extra liters of fluid on board, right? Your heart failure patient. That is why the daily weights are so important, is because we are able to see, because they're not going to pack on 5 pounds worth of adipose in 2 days. They will pack on 5 pounds worth of fluid easily in 2 days. Okay, if we're not watching the I's and O's and weighing them daily, or teaching them how to do the daily weights. That is a very important piece of discharge and home care for heart failure patients, is how to weigh, when to weigh, how to do it. Same clothes every day, same time of the day is good. the same scale, so that they can track for themselves, am I gaining weight? In this case, it's not a body image issue. It's a, am I going to be able to breathe in 3 days issue? Cardiomyopathy, cardiomyopathy, right? Cardiac muscle disease, right? So you have the different types, the dilated, the hypertrophic, or the restrictive cardiomyopathies. These are covered in your textbook fairly well. So muscle disease, think about their impact as you're reading that. What is the impact on cardiac output and why? Infections and inflammation. Oh yes, inflammation, my favorite thing, right? Chronic rheumatic heart disease. Right, so rheumatic heart disease brought on by bacterial infection, which then impacts structures in the heart, valves especially, can lead to deformation of the valves, and if the valve doesn't seal, blood leaks back through. The heart is not as effective a pump when the blood is coming back through the valve into the previous chamber. Makes sense? These patients, depending on the severity of the damage, may in fact be candidates for valve replacements at some point in their lives. Bacterial endocarditis. Here's one that's going to bear a little bit of explanation. So the layers of the heart. You have the inner layer, the endocardium, endo inside, and you have the myocardium, the heart muscle. You have the epicardium, the topmost layer where the pericardium attaches, right? So epicardium, myocardium, or endocardium, right? The inner layer. Your valves, they look somewhat like parachutes, as you can see from the examples in your nursing text in your bio book. The edges of those valves have little strings coming down, of course, it's called the cordae tendineae, that attach to papillary muscles on the inside of the heart, on the inside of the chamber. Okay, so papillary muscles. Think about, so these cords are attaching to the endocardium at the papillary muscle. Think about what happens to tissue when you have inflammation. Does it get stronger or weaker? If you screamed weaker at your screen, then you would be, again, playing along and also correct. So tissues get weaker with inflammation. Endocarditis, inflammation of the endocardium. Those cordae tendineae are very important to keep because the valves are soft. They're much like a parachute. As long as they have their guy lines, they won't blow back out. So if the patient is stressed, if their pressure goes up, if their heart rate goes up and puts more stress on that heart, they can actually lead to a valve blowing out. And now think about this. So I got a squeeze here that pushes blood down into the ventricle. And then to stop, because the ventricle is strong, to stop that blood from just being squeezed back up into the atrium, I've got that valve there, that AV valve, that atrioventricular valve. If that blows out, then that blood is not being forced out through the next valve into the pulmonary or systemic circulature. It's being blown back into the atrium. All right. This markedly decreases cardiac output and can be incompatible with life. So a patient with bacterial endocarditis, make them as comfortable as possible. Pain and discomfort, that's not because they're going to die soon. No, pain and discomfort can increase stress, can increase blood pressure and heart rate. Instruct them to conserve energy. Keep the demand on the heart low. Because we're trying to protect those chordae tendineae so that the valves don't go floop. Frequently note the pulse rate and quality. So if our patient has a good pulse, you know, it's sitting at 68 and it feels good. It's not too strong. It's not too soft. And then all of a sudden, the next time I check it, the heart rate is up and the pulse quality, the pulse has become very weak and thready. In that case, we know that we have just lost a valve very probably. And we need to be on top of that, treating that patient, because that patient may require surgery rather quickly. Right? Fluctuations in body temperature or any symptoms of complications. Okay, symptoms of complications, right? We begin to lose cardiac output, but fluctuation in body temperature. What this might tell me is, because we're going to be treating this with antibiotics, so we want to knock out the infection so that the inflammation will go away and the endocardium will no longer be inflamed and no longer in danger of pulling those strings loose. So if we suddenly have a spike in a temperature, we know that we have not controlled the infection. Make sense? And that this is something that needs to be reported right away, no delay, because these patients are experiencing an infection that directly affects the pump that feeds everything else. Nextitis, pericarditis. All right, pericardium, that double-walled sac around the heart. Okay, so let's roll it back to tamponade for a minute. We got that double-walled sac. It begins to fill with fluid, and the heart doesn't have that much space to expand into. Pericarditis, we have the inflammation, again, can restrict the movement of the heart and also increase friction, which can cause pain and further inflammation. Coronary artery disease. What I'm going to have if I don't leave the McDonald's cheeseburgers alone. Although I'm told if I continue to drink coffee by the gallon, then that will, assist in that in eating lots of dark chocolate. That will assist in all that. That's what I told myself. So, coronary artery disease, AP, angina pectoris, chest pain. Very simple, chest pain. Substernal, a little bit to the left. So AP, temporary loss of oxygen to the heart muscle. Okay, because the heart never takes a break. It's a very greedy muscle. It has that third circulation that we've talked about. You've got your systemic circulation, you got your pulmonary circulation, you have your coronary circulation, right? It's very greedy. It drinks right from the source. It taps right off at the base of the aorta, feeds the heart muscle, dumps it right back at the base of the right atrium through the coronary sinus and circles that blood through. So it gets lots of oxygenated blood because it can't take a break. If it sits down and takes a rest, we have a term for that called cardiac arrest, and that's not compatible with life. So AP can be temporary loss of oxygen to the heart muscle, or a decrease to such an extent that the pain is brought on. Okay, that can be with those arteries looking like sewer pipes, or the arteriosclerosis so bad with the constriction that not enough is getting through, right? So AP into ischemia, myocardial ischemia, if that continues. So those cheeseburgers, that cheeseburger fest that you went on for the last 20 years has finally caught up with you. Your coronary arteries look like old sewer pipes, and maybe a little clot got wedged in there, further cranking it down. So you've got ischemia. If that is not corrected, then you get myocardial necrosis. You get dead meat. And folks, dead meat don't beat. Yes, I said it. You will remember it. You better remember it. It's on a test somewhere. Dead meat don't beat. DMDB. When tissue dies, is replaced with scar tissue, which we have discussed before. Scar tissue is great at being scar tissue. It pretty much sucks at being everything else. Right? It's great at being scar tissue. If it's scar tissue in the myocardium, hey, the myocardium is supposed to contract. Scar tissue doesn't. So I have a piece of my heart muscle that doesn't contract. What's that going to do to my cardiac output? It's very likely to decrease my stroke volume. Right? So dead meat don't beat. With myocardial infarction, we have acute coronary syndrome, which an admitting diagnosis. The patient comes in complaining of crushing chest pain, and all right, so we treat for, we start ACS, all right, to rule out a myocardial infarction. Treatments, MONA, 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 my girlfriend. Morphine, write this down. Morphine, oxygen, nitro, and aspirin. Emergency treatment. Morphine has two, three of it. So it relieves pain. It relieves anxiety, which anxiety can increase the demand on the heart muscle. Right? And it relaxes muscle, which your arteries are smooth muscle, to allow them to dilate a little bit. It also relaxes the bronchi to increase airflow, until it depresses your immune system and you just forget to breathe. But you increase airflow that way to increase oxygenation. So there's morphine. Oxygen. We know we've got a loss of, or a severe decrease in oxygen supply to the myocardium. So what gets through there, we want packed as full of oxygen as possible. So there's morphine, oxygen. Nitro, not just for blowing bridges up. Nitroglycerin, no, you will not, if you drop the bottle of nitroglycerin that's hanging by the patient, you will not blow the hospital up. But nitroglycerin dilates blood vessels. And to the point where, especially in sensitive people, one, it can cause hypotension. Two, it can cause a screaming headache. Right? So nitro, dilate the vessels. Right? Get them as open as possible to get that oxygenated blood through to the myocardium, because ischemia we can deal with. It doesn't have. We're not talking about a permanent damage here. Necrosis, that's permanent damage. We want to avoid necrosis. And the last piece is aspirin. MONA. Morphine, oxygen, nitro, aspirin. My old friend Mona. Right? Why do they give aspirin? Makes the platelets slicker. What do platelets cause? Clots. So we want to minimize the formation or extension of a clot that might be blocking the arteries. So that's a cornerstone treatment for ACS. And then 12-lead EKG to see what's happening with the heart, and depending, maybe a GI cocktail, because sometimes GI issues can masquerade as chest pains. That's why you'll most often see, the diagnosis is ACS, rule out MI, right? Acute coronary syndrome. One thing you may find in your GI patients, just as an aside here, is those that have esophageal tremoring with GERD, hiatal hernias, and a lot of erosion. That tremoring can mimic cardiac chest pain in your patient, and it is also relieved with nitroglycerin. So that's why we don't just, oh yeah, took some morphine, it's a heart attack. We continue to do the testing, right? And then acute myocardial infarction, right, says it all. It's acute myocardium. We've got an infarction. We may have myocardial necrosis if it is not addressed and fixed quickly. Continuing on with inflammatory disorders. Thrombophlebitis. Okay, so what's the difference between thrombophlebitis and phlebitis? What is phlebitis? Phlebitis, inflammation of a blood vessel. Thrombophlebitis, inflammation of a blood vessel associated with a clot. It is that simple for you, okay? But inflammation of a blood vessel can cause that lumen to constrict. So if you do have a clot, that clot that might have passed through there, not done much damage, can get wedged. And then you have ischemia downstream of the clot, right? So an embolism, all right? So the difference between a thrombus and an embolus travels, all right? And an embolus may not just be a clot. It could be a piece of fat. It could be a piece of plaque that is broken off. In one case, a bacterial vegetation that came loose and got wedged. If you have to have an embolus, hope that it's identified and treated quickly, and hope that it's a thrombus, because that's a lot easier to break down than a big chunk of fat stuck in a cerebral artery. So the difference between a pulmonary, coronary, and cerebral embolism, we don't really have to go into that, do we? Okay. All right. We're on the downhill stretch, guys, and my computer hasn't crashed yet. Knock on wood. So peripheral vascular disorders. All right. Peripheral vasculature, legs, extremities, right? We tend to see it more in the legs because these are the bigger, most used muscles, all right? So intermittent claudication, pain that comes on with movement or exercise that subsides quickly with rest. Tingling and numbness, impairment to the peripheral nervous system. Coldness and difference in size can also be redness too, depending on the type of peripheral vascular disease. So if my left leg, lower leg, is cooler than my right and smaller, what do you think's happening with the blood flow? Is the blood flow to my left leg better or worse than the blood flow to my right leg? About that one for a second. And we're back. So blood flow decreased, right? Blood is nice and warm. Blood is a wonderful thing for transmitting heat. If the circulation is impaired to the extremity, then the extremity is going to be cooler. It is also going to be smaller, more than likely, especially in a chronic condition, because those tissues are not getting the nutrients that they need to really perform at their best, right? Difference in size. Now, that's for a supply side. If, say, my left leg had a venous issue, it may in fact be larger than my right leg because the blood is flowing in, but the outflow is impaired. And it'll also be, it won't necessarily be pale and cool. It will more likely be a little more red. Right? Lack of new tissue growth, meaning healing. Right? So with a arterial issue, you're not getting the supply, you're not getting the proteins needed for healing, you're not getting the oxygen, you're not getting the glucose to those tissues so that they can really do what they need to do to heal. Impaired healing, lack of new tissue growth. As we're rolling along here, review burgers, Raynaud's, varicose, and spider veins. Burgers, Raynaud's, you might see those again. Varicose veins, this would be normally where I would say, okay, nurses, along with, now I do not have a foot fetish, thank you very much, or a shoe fetish, or a sock fetish, but the best thing you can do, oh ye bedside warriors who are going to be standing on your feet for 10, 12, 16 hours a day, get good shoes and invest in compression socks, or invest in good shoes and get compression socks. Because varicose veins happen to those of us who stand all day. Last little bit, aneurysms. I'm going to give you, a little cue with the final, because there's a video that I love to show you guys, but we can't do that right now. So an aneurysm, an outpouching of the blood vessel. So an artery has 3 layers, the 3 tunics: interna or intima, media, inner, middle, outer. I may possibly have lost my mind. The epithelial lining, the smooth muscle, fibrous outer coating. All right, smooth muscle to constrict and relax, right, to help maintain blood pressures and blood flow. So what happens in an aneurysm is there's a weakness there, which causes an outpouching and a thinning of those tissues, which is fine as long as it holds until it pops. And then when it pops, we now have a hole in an artery. Holes in arteries generally contraindicated because they're high pressure. They like to bleed a lot. An aneurysm, depending on its location, can kill you rather quickly. So the forms, berry aneurysms, which looks like a berry. We're talking the circle of Willis. Of course, we're talking about cerebral circulation. Fusiform, dissecting. These are, now I will go with aorta here. Berry aneurysm, inside the skull itself. Keep in mind that your heart's going to keep pumping, and it's going to keep pumping through that leak in the artery, and is eventually going to try to crowd your brain out. With the abdominal aortic aneurysms, this is where I tell you, do not palpate the pulsating mass. I have had patients who have had very extreme abdominal aortic aneurysms, AAA is what we call them, where I could count the patient's pulse from the doorway. Now, that was a very skinny, on their way out hospice patient with a very large aneurysm. Regardless of the size, keep in mind the aorta is that first that's your water main that comes off the top of the heart and feeds everything else. That is the highest pressure and the most blood flow. And if that pops, your heart is just gonna keep pumping, and it will, the patient will die rather quickly. The likelihood of survival for a ruptured AAA is abysmally low. And then ticking down here, we will cover these more in depth next week in neuro. All right, so types of CVA. There's the TIA, the transient ischemic attack, generally considered to be as a result of vasoconstriction, temporary impairment of the blood flow to an area of the brain. Some call them mini strokes, right? They generally resolve without permanent damage. And then we have the cerebral thrombosis or cerebral embolism. All right. So a clot formed or a clot being wedged, or scarier, a piece of fatty plaque or something else that has moved from one place to the other. And then the cerebral hemorrhage. So two types of CVAs really that we're looking at is hemorrhagic or the thrombotic, embolic CVA. One is a blockage, the other is a leak. As you recall, when we were talking about medications, antithrombolytics, or not antithrombolytics, but thrombolytic therapy. Okay, one of the things that you had to know was, okay, recent CVA, was it, or current CVA, is it a case of a hemorrhagic CVA or a thrombotic CVA? If it's a thrombotic, that clot buster, that thrombolytic, will bust it down, restore blood flow, life is grand. But if it's a hemorrhagic CVA, the patient cannot clot, meaning they will continue to bleed into their brain until they herniate. Make sense? Fun, isn't it? So, results of the CVA. Now I want you to, okay, hemiplegia. Know your stages of hemiplegia. Foot stomp, gonna see it on a test. Flaccid stage, which doesn't necessarily mean what you think it means right now. Spastic and recovery stages. Aphasia versus dysphagia, right? And for that matter, what's the difference between dysphagia and dysphagia? Okay. One is PHASIA, the other is PHAGIA. Obviously, the result of a CVA may be brain damage, right? Hemianopsia. Patient loses half their field of vision. And I'm not talking goes blind in one eye. I'm talking loses half of their field of vision in each eye. So it's kind of like wearing double blinders. See, they lose half of that vision, right? One reason I'm not a neuro nurse, because neuro patients creep me out, guys. So hemianopsia, loss of half of the field of view, and right? Pain, all right. Well, as you're going to find out next week, headache is the number one symptom of a neurologic disorder, and pain, CVA, makes sense. Right? Disturbances in the autonomic nervous system and personality changes, both in the time and afterwards. Maybe complete personality changes. Rehab, because we're talking about this here instead of in neuro, because it is a vascular piece. All right. So rehab. The reason we do the range of motion and providing the exercise, we prevent contractures, because we're finding that the brain is a lot more plastic than we thought it was. And patients can relearn new pathways, depending on age. So if we prevent contractures, if we prevent joint disformities while they're doing it, then we provide the patient with the greatest chance of regaining function, the new normal, which is closer to their baseline. Does that make sense? Keep the skin intact. Turning. Remember that the patient may not be able to feel that they are having pain. Right? So keep the skin intact, skin care, repositioning, right? um, keeping the bowel and bladder, changing briefs quickly, checking quickly, checking frequently. Bowel and bladder training is a great thing for the patient. Moving on towards, being as independent as they're going to be. Right? Adaptive ADLs, because they may regain some function, but they may not come back to their baseline. So teaching the patient new ways, they're teaching them how to exist within their new normal. Okay. And then beginning therapies as soon as possible. The sooner you start the therapy, the sooner you can begin to, the patient begins to rebuild those abilities. And that, kids, is it. Um, enjoy the weekend. Hopefully I didn't embarrass you too much with my horrible drawings. And next week is neuro. Timesheets. That is all.